Today we have Dr. Justin Dial. He's going to give a presentation on exercise as a pill for aging, how to impact participation in rehabilitation and wellness. I love that title, Justin. So thank you so much for being here. Just so that you guys know a little bit about Justin. Justin Dial has served as a clinician and a faculty member for over 20 years, while passionately devoting his career to optimizing the health and the well-being of populations in need. Dr. Dials has a sincere interest in mentoring and preparing students that will allow them to dramatically impact the future of cardiovascular research, preventative medicine, and health and wellness. So we welcome you, Dr. Dials, and we are ready to hear about how exercise is a pill for aging.
First of all, I want to say thank you to Pamela and to everyone who's welcomed me to Louisville. I've only been here for a few years, but I've enjoyed my meetings with the folks at Traeger. You're fun. I think you just get it. And I got a chance to meet one of the only other Justins that I know.
Wow.
My mom and dad almost named me Peace. Or Love. One of the two. So I'm glad to be a Justin.
That's neat.
Yeah, it's not too neat. Okay, so the title, Justin, can we go back one slide real quick? I'm going to try to get this done in 20 minutes. Pam mentioned the title. The title is really, really meaningful for me. And I think one of the last slides, I'm going to circle back to why it is. But exercise as a pill for aging, there is a global initiative called Exercise as Medicine. And it really can serve as a pill. So exercise does it all. It can do some of the things that beta blockade do. It can affect your vagal sympathetic balance. It can impact the whole RAS pathway, insulin sensitivity, all the above. So it really is a pill. We always told our patients, line your pill bottles up and we'll give you an empty pill bottle that says exercise on the card. You're going to put it in the pill bottle. By the end of the day, you want that thing out. And of course, at night, you put it back in. And then how to impact participation, rehabilitation, wellness. Rehabilitation and wellness, I made that separate than exercise. Exercise is a component of rehabilitation and wellness. But my job is to speak exercise today. Of course, the rest of some of the other folks on this call, their expertise is mental illness. Their expertise may be nutrition, so forth and so on. Okay, next slide. Back to the exercise is a pill. Dr. Butler, formerly of NIH, if exercise could be packed into a pill, it would be the single most widely prescribed and beneficial medicine in the nation. I think prescribed and beneficial is key. Would it be the most taken? I don't know. I mean, a lot of patients aren't the most compliant with medication. So if we had it, it would be there. I'm glad they didn't say that it would be the most utilized. And then the Earl of Derby, I've used this for some time. Those who think they have no time for bodily exercise will sooner or later have to find time for illness. Some of the irony of the Earl of Derby is that there's family lineage to Sir Stanley of the Stanley Cup. And of course, we all know how physically active hockey players are. So I thought I'd throw that little tidbit in there. Physical activity and exercise are really two different things. And exercise is a form of physical activity. Exercise in and of itself is programmed, it's pre-planned physical activity. It is more intense than your basic traditional physical activity. However, the benefits of physical activity have been known for years. Back in the 1950s, one of the landmark studies was done on the shoremen in San Francisco. And these folks, these longshoremen, for 18 years, they collected data. The folks that worked on the docks and that did a lot of the manual labor were included, but so were the folks that worked in the offices. And they determined that following these folks for 18 years, those that racked up the most activity, and they measured this, they estimated it in calories per week, lived the longest. Because so we're talking about fatal coronary disease here, and as well as cardiovascular mortality. So that was just subjective. Okay, it was very, very subjective on what they did for work, and they used some of the equations that nerds like me use to estimate energy expenditure. And then decades later, a dear friend of mine, Dr. Martha Gulati, who is currently at UCLA, when she was at Rush in Chicago, she'd was a part of the Women's Heart Project, and they looked at over 5,000 women who were in the clinic for prognostic reasons. They had known heart disease, or they were there for diagnostic reasons. They were very suspicious of having CAD. And they performed basic cardiac stress tests, no imaging, on these over 5,000 patients. And they found that the higher the exercise capacity, and I'm going to refer to this as clinical fitness level. And a MET is a metabolic equivalent. If you know anything about oxygen utilization, it just is an abbreviated number or figure for mLs of oxygen per kilogram of body weight per minute of time. So a MET. And they looked at these folks and they adjusted it for the Framingham risk score, your cardiac risk score. And even after adjustment, the folks that had a functional capacity or a clinical fitness level of less than 5 METs, they were associated with a higher risk of all-cause mortality. And I use this all the time when I see patients is less than 5 METs is bad, 5 to 8 is not good. You want to reach that 8 threshold. So if you're above a functional capacity, a clinical fitness level of 8, not out of the woods, there's still risk, but you are sitting pretty good. So again, this represents clinical fitness, which is a measure of how they exercise and how physically active they are. Okay, so what about the aging population? Those studies that we talked about with the longshoremen, the average age was roughly 52. With Martha's study, the average age in the longshoremen was anywhere from 48 to 65. The average age, the mean in Martha's study was 52. So we really haven't, there's not a lot of data. There is data. There's not a lot of, elaborate studies focused on the effects of exercise and physical activity in the aging population. However, what we do know is some researchers look at aging and they have the 7 pillars of aging. And I got to put my glasses on to see some of these small words. Of course, we have the macromolecular, we have the dysregulated stress response, we have disruption in proteostasis, which looks at cellular stress or reactive oxygen species. We have metabolic dysregulation, which is huge. Anytime you have metabolic dysregulation, you have some defective mitochondria or mitochondrial dysfunction, which can obviously impose threats upon the ability for you to create ATP and substrate utilization. Epigenetic drift is humongous. That's where we see a lot of methylation, and we see some changes in phenotype come out, aged stem cell, and then this chronic inflammation over to the right. Chronic inflammation, we're looking at cytokines. We've all heard CRP or high sensitive C-reactive protein. If you want to get down to the nitty gritty, we can measure, although very expensive, is your interleukins, TNF alpha, all of these mediators of inflammation that can cause disruptions into some physiological systems. But essentially, this is a risk factor for age. Okay. And some of the most important aspects on this slide are to the right, where you see muscle atrophy. Right, we have disruptions in the mTOR pathway. It's kind of counterintuitive. Of course, mTOR, we know that downstream of that is it's very, very important for protein synthesis, but it's the dysregulation of it that can become problematic. And then in the middle, down to metabolic dysregulation, the defective mitochondria. It's those two aspects is where I want to spend a lot of time, because we know that exercise can impede any detrimental effects of those properties. All right, I look at 2 different phenotypes when I look at patients in general. And then there's this huge continuum of risk. And I look at, when I think of exercise therapy or therapeutic exercise programs, the first thing that comes to my mind is preventive cardiology. That's just how I think. And you can use preventive medicine. I think it's one and the same. It's just the fact that most of my life I've worked with cardiac patients. So what we see is this primordial preventive medicine. And primordial is, let's stop the onset of the risk factor. And then primary prevention is, well, you know what? You have the risk factor. Let's keep it in check and let's eliminate, right, or at least reduce the likelihood of that first event, the heart attack. the onset of peripheral arterial disease, the onset of diabetes, the onset of hypertension, and so forth. And so when we're dealing with the healthy population here on the right, they're more than likely already using physical activity as preventive medicine. Okay. They've already applied the physical activity and exercise. There's very few exercise deficiency diseases. Their physiological systems are in check, and they have a reduction in time to morbidity and as well as mortality. That's the healthy phenotype. Now, we still see some of these folks in the aging population. A lot of these folks get the benefit of, in the middle here, this middle rectangle called genes. Right. And I'm a big believer in people that respond to medications, people that don't, people that respond to exercise, and people that don't. And genetics plays a major role. On the left side, the non-healthy phenotype is what we deal with the most. They're going to be in the office because they're not the most healthy. And so there's no application of physical activity and exercise. We do see some exercise, some diseases related to exercise deficiency or not enough exercise. And I want to stop and say that's the low clinical fitness. These are the patients that have less than 5 MET capacities. Again, metabolic equivalent, low VO2, low clinical fitness level. And then the pathological regulation of these diminishing processes. Okay, it's environment, it's diet, it's genes. That's sure, certainly it's involved. But the lack of exercise and physical activity just, takes these disease states you have and just blows them up. So the increased time that you're in this morbid state, and then the decreased time you have to death certainly sets in. So you look at on the right, we have exercise and physical activity already utilized by these patients. And then on the left, we have to implement physical activity as exercise therapy. And that is the elephant in the room. And I think that is why we're here today. At least that's why I'm here today. All right, I love this slide. On the left, we have this cycle. And up top, it says disease. And the way I want to look at disease today is the set of diseases of aging or aging-related diseases. Anywhere from Parkinson's disease, and anywhere from renal dysfunction, the diabetes, insulin resistance, hypertension, cardiovascular disease. So the fact that we have these diseases that have already set in, right? That's kind of the moment, or this is the circumstance that I want to portray. So a patient has the disease, why they get it. We went for the issues on the previous slide. Now we have it. So the biggest issue in these age-related diseases from an exercise standpoint, okay, is number one, sarcopenia. And sarcopenia would be a loss of muscle mass without a significant change in overall weight. Okay. We're not in this cachective state yet, right? There's no cachexia that's been initiated, but just a loss of skeletal muscle mass. It's normal. It happens with aging. Just like with aging, we see an increase in arterial stiffness. That's associated with aging. We see a reduction in our ability to handle insulin. It's just a matter of aging. So with sarcopenia, if we have a lot of loss of muscle mass, it's a problem. I mentioned VO2 max. Again, here we see this word VO2 max. And I want to just go on and define this a little more. The V is the volume. Of course, O2 is oxygen. And then M would be maximal. It's your maximal ability to take in, circulate, and then utilize oxygen. Where do we utilize it? During exercise, skeletal muscle. Okay. So the more skeletal muscle, in theory, the higher the VO2 max. Of course, there's central parameters such as pulmonary and cardiac, stroke volume, cardiac output being one of the major players there. So VO2 max is instrumental. Again, that's the clinical fitness level. It is one of the biggest risk factors for disease. And again, as we said before, one of the biggest risk factors for cardiovascular and all-cause mortality. To the left there, we have strength and power. I think this is the most, I'm not going to say underlooked, I'm not going to say underrated, but for whatever reason, it is the most underutilized, okay, therapy that we have. And I've seen this in the older populations. I've seen this in cardiac patients. I've seen this in pulmonary patients. We just don't utilize therapies to increase their strength and power. And with the aging population, that is everything. Stroke volume, cardiac output in a healthy patient, in a non-cardiovascular disease patient, it's normal. We don't see many issues typically with stroke volume and cardiac output. What we see is, again, the peripheral portion of the VO2, it's the skeletal muscle. Okay. And then if we move on to the left, obviously, if we have reduced strength and power, if we have reduced aerobic capacity or VO2 max, we have issues with our walking speed. We simply don't walk as fast, so we don't burn as many calories when we exercise. This leads to disability. This leads to a reduction in independence, which leads to a reduction in activity. Reduction in activity is reduction in total energy expenditure. And then this just cycle continues and continues. I do want to say that if they reach the area where it says reduce walking speed, and you see the arrow that says disability, at this point is where I typically see the psychosocial and the mental aspects with aging. Some of these folks just, they can't walk the dog around the block. They're losing their balance. They can't stand up for an extended period of time. They can't go to the mall and shop because they become fatigued or their muscles become sore. So this is where walking speed, or even your ability to walk before the onset of symptoms, is crucial. And it's one of the outcomes that I collect when I establish therapeutic exercise programs. On the right, we see images of there. It's a cross-section of the thigh. In a 25-year-old man, we see significant muscle. There is some fat mass there. But if you look at someone who is in their 6th decade of life, we see significant muscle atrophy and more fat mass that surrounds the muscle. So this is an example of reduction muscle mass, or what we call sarcopenia. The more sarcopenia, the less strength and power that one can produce. Next slide. Okay. The middle slide we've seen, and looking at strength and power and VO2 max, we'll look at the left side first. The left side represents functional capacity, or VO2 max, okay? Or muscle strength. You know, there's no numbers or values here. The bottom line is that as we age, we lose functional capacity, okay? Now, the sedentary, or the thick dotted line, we can see a clear drop-off. The emphasis of this slide is to look at the middle line, which is active. We are always going to see limitations and reductions in maximal capacity, whether it's strength or whether it's aerobic capacity with age. We can't change that, okay? It's not going to happen. What we can do is we can slow down the process. And if you take a look at what happens in someone who is trained, and I'm not talking about someone who is a master's athlete. I'm not talking about my old mentor and boss, who is a 70, I think he's 75 now, maybe 73-year-old male who has completed, I think, 6 Ironman competitions. Okay, he's a freak, okay? He's one of the smartest men I know, but he also has his PhD in exercise physiology, and he's a cardiologist, so he's big on this. I'm not talking about the highly trained people, those that become trained, those folks that we bring into our clinic, our institute, who have a MET level of less than 5 METs, and now they're at 8.7 METs 12 months later. So their trained state allows them, from a functional capacity standpoint, to have that level of a 53, 54-year-old male or female, okay? So that's how activity works. You go to the right, now this is strictly muscle power. We can assess this. We don't have the equipment to assess this at the Institute. We do have this at our exercise physiology lab on main campus. And if it's VO2 or if it's power, they both begin to significantly decline between the ages of 35 and 45. So roughly around the 4th decade of life is when we see significant reductions, okay, in both VO2 max and maximal power. And so myself, I'm 49 years old. In high school, I lifted a little bit, but my DNA just doesn't allow me to put on a lot of muscle mass. Okay, my football coach said I was all heart at my senior banquet, and I still don't know if that was a put down or if that was a compliment. Okay, now my son is different. My son's big. I don't know whose DNA he got. Maybe it's the milkman. Maybe it's a stranger off the street. I don't know, but he's strong. And so I started lifting weights because I don't want him to get stronger than myself. But in hindsight, and I should have been lifting already. Okay, again, late third, fourth decade of life is where it becomes paramount to strength train. Because if you don't, obviously, 6th decade, 7th decade of life, it becomes paramount in as far as your disease risk. So next slide. What is and how do patients exercise? If anyone has any experience with American College of Sports Medicine, American Association of Cardiovascular and Pulmonary Rehab, anything out there, you can find this. You can Google this. Okay, I don't believe it's certainly not brain surgery. Okay, and we haven't really reinvented the wheel. Guidelines have been similar to this for decades. So what we're talking about is frequency, volume, intensity, and time. So for the typical aging individual, of course, we'll do some sort of survey on the left, right? We want to get an idea of where they're at. And then when we get them to training, 2 to 3 days of resistance training, 3 to 7 of aerobic exercise training. There is some balance training, which is specific to this population, but this is really no different. If you take a look at the volume, 1 to 3 sets, 8 to 12 reps, that's what I do. That's what my son does, okay? Time, 20 to 60 minutes. That goes for everyone. You look at intensity. The one difference about the aging population, I treat these as if they were heart disease patients as far as intensity. So I start low, go slow. It says 30 to 40% of 1 repetition maximum. That's not a lot of weight. So we're starting low, going slow. If you look at the aerobic exercise training, a 12 on a Borg scale, it's a rating of perceived exertions, relatively low, at least in my opinion. 55% of your maximal capacity is low, but it's okay. I'm looking at the aged patient as I would someone with established cardiovascular disease. And some of the physiological adaptations are in line, concomitant with what we already know. Increased strength, increased power, increased hypertrophy. The issue here is that at an aged individual, we're starting at the very low end. Okay, and the issue is, how do we incorporate this? This is not rocket science. Again, it's not new. How can we incorporate this into their life and still keep them happy? It's very hard to engage someone who's never done this before, and now their physician's saying, you know what, I want you to go see Justin. He's going to put you on an exercise program. And they don't show up. And we get them there. And then they come 2 times and then they don't show up. It's hard. And so the art is finding the right volume, finding the right intensity that suits, number 1, their functional capacity, but 2, what they want. I mean, what do you want to do? It's the same as physicians. That I remember talking to a physician when I first moved to Louisville, and I went in there and she said, okay, you're pre-hypertensive, you're this, you're that. These are the prescriptions you're going to take. And I was out the door. Well, I took them, so I don't want to be known as one of those patients that you guys despise who's non-compliant, but she never asked me. Okay, so I always take the time to say, what is it you want to do? Why are you here? Well, Dr. Furman told me to come here. That's why I'm here, damn it. That's not enough. Okay. Now, really, why are you here? And if you ask first, that goes a long way. But again, so it's an art. Even though this is basic, you can utilize this, and you got to individualize it to your specific patient. Next slide. Okay, this is very, very, very important. And I know I got to go here. I'm already running over. But how does this work? How do we get a patient into a therapeutic exercise program in an Institute of Aging? First is the evaluation. Always starts evaluation. They're going to see their primary care provider, the physician at the Traeger Institute, and it's going to start with the direction. I'm going to evaluate the patient. Do they go to physical therapy first because their strength is so bad and their balance is off? Let's punt them to the physical therapist first. When they get some strength and when they're able to exercise with me, EXRX is exercise prescription. That's when they would come to the Institute's exercise or therapeutic exercise program. This is the biggest thing with exercise. As you look at the bottom left corner, the largest predictor for a referral and patient participation is the physician endorsement. This sounds like it's no duh, what are you talking about? But it's not done. You'd be surprised. Physicians have so much time, 15, 20 minutes out the door. Okay. We want you to see 25 patients today. There's not a lot of time, but it is that brief 25 to 30 seconds. Okay. This is what I this is what would be beneficial for you. I want to make the referral to our therapeutic exercise program. I'm going to call Dr. James. I'm going to call Dr. Dials, whoever it is. And even yet, if that clinician is in your clinic. Now, I realize this is not feasible, but the way it worked for me, the best program I ever had was they would just call me and say, Justin, can you come up, see this patient? I just described the program. Can you elaborate a little bit and get them fired up to start? Then they leave your office with the referral, with an appointment, with the initial appointment. That is the first step because it's backed by evidence, not a lot of evidence. There's been 2 studies that show the overall efficacy that's tied into that initial encounter. So what happens then? We get them in the program. I mentioned before, we do neuromuscular, work on balance, work on strength, and then eventually we put them in the aerobic exercise portion of the therapeutic program. And this is optimized risk reduction. The biggest way to do it is through aerobic exercise. If you want to, again, significantly reduce risk for cardiovascular disease, but both are important. Maintenance, what's maintenance? Maintenance is when they're done with your therapeutic program, where do they go? Do they go home? Do they go to another gym? We've got to keep this up. Next slide. Okay, I mentioned before, difference between physical fitness or VO2 and physical activity. Harder is better from a risk reduction standpoint. I think there is no blurriness to it. It is black and white. Harder is better. Harder is better. Okay. But is harder doable? Okay. Is there a gray area? If we have patients and say, you know what, you're 82 years old, but you're relatively healthy, there's no reason you can't exercise at 80% of your maximal capacity, just like Pam does. All right. What are you, Pam? I think you're 35. Yeah, Pam's like 35. So there's no reason you can't exercise like her. Well, they're going to tell you to go jump in a lake. So I know that harder is better, but you've got to treat that patient as if they're the only patient in the world. So this talks about acceptability. What's acceptability? They accept the program and they maintain compliance with the recommendations and the program. So if you make it, if they enjoy it, okay, is it a joyous environment? You got to make it fun. All right, you got to have some personality. When I would interview people who have, unfortunately for them, no personality, you can tell that they've texted their life through college. They can't speak to anyone. All they've done is communicate via text or email. They can't speak to people. And you need that person on your staff that can make it fun. And then they got to see value. And here's the thing about aged people. When you run an exercise program with heart patients, we teach numbers. This is your blood pressure. This is your cholesterol. Okay. These are your liver enzymes. You know, this is your blood sugar level. Aged individuals, it doesn't really work. They don't really care about numbers so much as I do. What they care about is what they can see outside of numbers, which is, I don't get out of breath that much when I walk through Kroger. I can walk the dog now and feel better. Okay. I took 10,000 steps today. I took 5,000 8 months ago. It's what's tangible to them that means the most. Let's give you another exercise test. Doggone, now you're up to 7.9 meters. You were at 5.2 12 months ago. That's what means the most to them. So it's fun and it's what they perceive value to be, which a lot of times is not so much getting caught up in blood pressure, cholesterol, lipids, so forth and so on. The next slide. Okay, now this is, how does a program function? Before we talk about getting into the program. So let's take a look at this set of gears here, and I know I got to go. To identify and treat, first and foremost, you identify them in the clinic, you put them into your program, their therapeutic exercise program. Now, numbers for me mean something. So I'm collecting outcomes, whether it's lipids, blood pressure, central blood pressures, arterial function, VO2 max, and we're going to be on the cutting edge. My programs, typically it's all evidence-based, but yet it's cutting edge. Okay. And I have a lot of ideas of exercise intensities with women, specifically postmenopausal women. That's some of the research that I want to implement. I think we can do that at the Institute. But look at this middle one, the facilitation to facilitate the transition to patient. This is probably the most important part of any therapeutic exercise program, aside from the initial message that the face-to-face interaction of the physician. You can only spend so much time, in my opinion, in a clinical setting, a clinical gym, a rehabilitation setting. You want to punt these patients out the door and get them on their own. Okay. It's analogous to me having parents call me as a professor when their kids are 22 years of age, complaining that I mistreated them or I gave them a D when they probably deserved an F. And it's these helicopter parents. Okay. You don't want to be a helicopter clinician. Now, the patient may fall in love with you in the program, and it's great to maintain a relationship, but transitioning them to facilitate them to where? To home. Maybe it's to the area YMCA. I think that's a very, very big, a very, very important initiative that the Institute wants to take care of, is to get these folks to a Y. Okay. But it's maintaining the facilitation, not just from one patient, but having this relationship. Actually, it turns out that a patient's compliancy with their exercise program is the same whether they go home, whether they go to a YMCA, or whether they come back to your clinic, say once a week. As long as you move that last gear, which is a continuous follow-up. So once we punt, say Pam is 84 tomorrow and she comes in for the program, poof, she turns 84. She's done with our program. We send her home. She wants to exercise at home. Well, you know what? In 1 month, let's do a virtual session, a virtual exercise session. We can actually charge for those. They don't get reimbursed. It's self-pay. Maybe we charge $20. Okay. Or maybe your follow-up is going to be in the clinic with that physician. When we're done, let's send you downstairs to the gym and let's do an exercise session. That's the follow-up. Okay. And again, maintenance, it doesn't matter really if it's in the office, if it's home, if it's phone, if it's virtual. What we got to have the follow-up and keep them in the program. Next slide. Okay. To end, one of my most dear patients I've ever taken care of was back in the year 2001. His name is Andy Anderson. And he was the oldest, he's the second oldest patient I took care of. This guy, I think, was 85, 86. I did have a 90-year-old. But Andy Anderson had a fairly aggressive coronary disease. And he was in for multiple stents. And again, the guy came in, not with a bad attitude, very reluctant to do anything. And, cardiac patients go through a program for 12 weeks and we have this graduation ceremony. And I remember him giving this to me. He actually came back when I left Mansfield, Ohio, when I moved to Columbus. He came back and said, I heard you were leaving. I want to give this to you. And it was never give up. This is one of my favorite pictures ever. Okay. And he said, you guys, not just me, as my staff, the physicians in the clinic, treated me as a patient, not a number. He said, I've been through my entire life. He had been sick, and very few clinicians do that. And he said, I get it. This day and age, the cardiologists are told to see 25 patients a day. That's a lot. He said that the clinicians that do the rehabilitation and wellness, we didn't treat him as a number. Now, I know by now he's passed on, but Andy was, he's one of the best guys I've ever met. That being said, he also said, I didn't want to come here, but after a few sessions, I realized that it's really analogous to taking a pill. Now, his synopsis, when he said that, he was about 10 years before the American College of Sports Medicine came out with exercise as medicine. So Andy, an 85-year-old cardiovascular disease patient, really, I think he could have made a lot of money for coining that phrase, exercise as medicine. Okay. So that being said, I know I went fairly fast. I know I ran over. I hope this was beneficial for everyone. I look forward to continued collaboration with the folks at Traeger to hopefully establish this holistic, unique, and groundbreaking therapeutic exercise program.
Justin, this was great. Thank you so much for this deep dive. I think we're talking about some of the takeaways. It's about exercise is just as much as the air you breathe and the food that you intake. You got to exercise every day. And the interesting thing is that I've been doing a lot of reading